Hello, everyone, and welcome. My name is Barbara Cochran, and I'm the director of the Dutournier Center for Healthy Aging here in the School of Nursing. And as usual, today I'm representing the Northwest Geriatric Education Center, which is sponsoring this geriatric healthcare series. Just a reminder that your site coordinators have information about how to access and sign up for contact hours for continuing education. And today I'm very happy to introduce to you Dr. David Park. He's a UW Professor of Medicine and an Adjunct Associate Professor of Global Health. His interests include lung infections, general pulmonary medicine, and critical care. And today he's going to talk about a very important topic for older adults, and that's pneumonia in the elderly. And welcome.
Thank you, Barbara. Okay. Hopefully I can manage this complex technology here, and I hope everyone can see my slides. And I'd love for my slides to advance.
You have to click those arrows at the bottom. Do you see them?
Yep, I have to click on that? Sorry.
Yeah.
All right, good.
Oh, you got it, okay.
So this is my outline. I'd like to, first of all, just briefly go over the pneumonia in the elderly background information, and then I want to walk through a practical clinical approach to managing pneumonia in elderly patients with the following steps. First of all, is it pneumonia? How bad is it? What's the likely cause? What's the best treatment? How should it respond to treatment? And what should you do if it doesn't respond as anticipated? So what is pneumonia? Well, it's inflammation in the lung parenchyma. And in your slide, you can see on the left the normal lung tissue, and on the right, consolidated lung tissue with the alveolar spaces filled with purulent exudate. Most of the pathology of pneumonia is actually due to the host response to the infection and not to the infection itself. So it's something that our bodies kind of do to ourselves. What's elderly? I thought I should probably know this for this particular talk, and I couldn't come up with a definitive answer. I know that I got my first AARP application when I turned 50. I know that there's something to do with retirement that starts at 62. I know a lot of things happen around 65, and then on from there. So I don't know, but I'm thinking of old people by age and old people by mileage. So what's the deal with pneumonia epidemiology, at least in the United States? There are probably 2 to 4 million cases per year. 500,000 require hospitalization. That's about 1 out of 5 pneumonia cases. The mortality varies a lot, which we'll come back to, but it can be anywhere from 2% to 50%, depending on the patient and the site of care. Pneumonia and lower respiratory tract infections account for about 10 million to 12 million physician contacts annually, 20 billion in annual expenditures, and pneumonia has varied between the 6th and 7th leading cause of death in the U.S. Globally, it's the leading contributor to the global burden of death and disease around the world. Here's where things stand with pneumonia and influenza as compared with heart disease, cancer, stroke, COPD. You know, it's not the leading cause of death, but if you want to look at it this way, we're making tremendous progress in reducing the occurrence of death due to heart disease, cancer, stroke, accidents, suicide, liver disease, but unfortunately deaths due to COPD, diabetes, and pneumonia or influenza are rising over recent decades. So it may become more and more prevalent as time goes on. as a cause of death. This figure just demonstrates the ultimate lobar pneumonia with pathology findings in the left panel and an X-ray showing lobar consolidation with air bronchograms on the right. So I want to talk for a moment about pneumonia pathogenesis. And the way that I'd like you to think about this, and particularly as it applies to older people, are routes of lung inoculation and then determinants of infection if you become inoculated with a pathogen. So what are the routes of inoculation? They're fairly straightforward, I think. You can aspirate pathogens into your airways. You can inhale pathogens into your airways. Pathogens can enter your lungs and air spaces via the bloodstream, and they can enter the lung via contiguous spread, if you have a chest wall abscess or something of that sort. That's less common now that we're treating everyone with antibiotics at the drop of a hat. Once you are inoculated, then what determines the likelihood of infection? A big thing is the virulence of the pathogen, the inoculum, how many bugs were inoculated, and a crucial thing that we focus a lot on in the clinical setting is the status of the host defenses. Okay? What are the lung host defenses, and what can we do about them? This is kind of a very comprehensive long list of lung host defenses. We have anatomic barriers, we have airway reflexes, we have our mucociliator escalator for clearance of mucus. In the alveolar spaces, we have soluble factors like defensins, we have cellular defenses including phagocytes and lymphocytes, and then we have cell-mediated immunity that's critical for defenses against pathogens such as tuberculosis, for instance. The risk factors for getting pneumonia include the extremes of age. Number one, so if you're very, very young, or in our case, very, very old, very high mileage, your risk of getting pneumonia goes up markedly. And this is especially so if you also have habits such as smoking, drinking alcohol, or illicit drug use. Comorbidity, especially COPD, heart failure, and diabetes. If you have some propensity for aspiration, such as seizures, loss of consciousness, or dysphagia. If you have an airway abnormality, such as bronchiectasis, lung cancer, or a foreign body in your airway. If you have an immunodeficiency systemically, such as HIV or cancer, or immunosuppressant drugs like steroids. And finally, if you just happen to be a young, healthy person minding your own business and you're exposed to a highly virulent pathogen like the influenza virus, it can knock you out. So age in and of itself is a very severe risk factor for getting pneumonia, and age, unfortunately, tends to be accompanied by many of these other factors. As we get older, we accumulate more host defects that make us more susceptible to pneumonia. Now, when you look in actual series of pneumonia patients, and these are a group from Harborview that I reported some years ago, and a sort of simultaneous group from Johns Hopkins. We didn't see a lot of those things, really. There was some HIV, more at Hopkins than at Harborview. There was some people on immunosuppressive therapy, but very few, really. And what we saw mostly were smoking, alcohol, and COPD. And those are really common host defense defects in patients who have pneumonia. So what formerly was probably best described as an acute lobar pneumonia due to the pneumococcus or the Friedlander's bacillus. The face of pneumonia has really changed over time. So we've got our aging population, number one. We've got bad habits. We've got chronic diseases. We've got salvage of severe illness. We've got immunosuppressive drugs. We have AIDS. We have socioeconomic hardships, rising antimicrobial drug resistance, maybe some impact of vaccination, maybe not. New antibiotics occasionally come out. People experiencing foreign travel, picking up new pathogens from other parts of the world. And we have new studies and guidelines and pathogens that are being identified. So it's become quite challenging to keep track of all this. So we'll try and keep it simple. One way to do that is to categorize pneumonia patients in ways that help understand why they are how they are. So I'm really trying to focus mainly on community-acquired pneumonia in this presentation. There is a severe community-acquired pneumonia subset that we'll talk about later on in terms of pathogens and treatment. But that basically means people who require ICU admission. And then traditionally we've had hospital-acquired pneumonia, which is another step or two down the list here, ventilator-associated pneumonia, and most recently ventilator-associated tracheobronchitis in people who have a ton of gook in their airway but nothing on their x-ray. But the one that I want to make you aware of, although I won't be talking about this a great deal, is healthcare-associated pneumonia. And this is where, in the past, when we talked about community-acquired pneumonia, we said, but this doesn't include people with HIV infection. This doesn't include people who live in nursing homes. This doesn't include sick old people, okay? And so I'll try to refer to that population as we're going through the community-acquired pneumonia guidelines and so on. But be aware that there is now an additional category, healthcare-associated pneumonia. And the reason that it's drawn aside is because the patients tend to get infected with drug-resistant pathogens like MRSA and Pseudomonas and things like that, whereas community-acquired pneumonia patients usually don't develop infections with those kind of things. All right, so let's talk about community-acquired pneumonia. This is, as I've pointed out, a very common cause of morbidity and mortality. It's growing in importance. More and more people are dying of pneumonia as time goes on, whereas we're making a great impact on deaths due to heart disease, stroke, and cancer. Known risk factors are very common. And it's possible to find a specific etiologic diagnosis, but the guidelines that have been put out by the professional societies have focused on empirically choosing antibiotic therapy based on the clinical setting and not investigating to a great extent what the precise cause may be. So we have the clinical setting, we have pneumonia severity, and then other identifiable risk factors for drug-resistant pathogens that need to be taken into account. All right, so first of all, is it pneumonia? We think it's pneumonia. Is it really pneumonia? So what do we think of as pneumonia? It's an acute illness, usually. Meaning a few days or a week or two at the most. There need to be appropriate clinical features. So usually 2 or more of fever, cough, chest pain, sputum production, dyspnea, rigor, sweats, confusion, abnormal chest exam findings, and or leukocytosis. And it's important that the X-ray findings be new. So if someone has pulmonary fibrosis, they may have had that for 8 years. That doesn't mean it's suddenly become pneumonia. So it's helpful if you have records of past x-rays and so on when someone comes in with what appears to be a new case of pneumonia. This is maybe the most important slide that I'll show you regarding advanced age. So these columns show different symptoms that occur and the frequency with which they occur within different age groups. And if you, just to keep it simple, look far to the left in the 18 to 44-year-olds, and you can see the cough, dyspnea, pleurisy, fatigue, fever, chills are pretty high. But tachypnea, and if I had a row for hypoxemia, would be similar, are very low. Okay? But then head out toward the 65 greater than 75-year-old group, and they still have a lot of cough and dyspnea, but it's significantly lower than in the young population. They rarely have pleurisy. They have fewer instances of fever and chills, and they're much more often tachypnic and hypoxemic. So their pneumonia makes them sicker in an important way, without important clues that we like to think of. Fever, chills, purulent sputum production, and so on. So think about pneumonia, particularly in an elderly person who's off their feed, who isn't right, who's breathing fast, who's hypoxemic, and don't count on seeing the classic presentation that your 24-year-old person will demonstrate. If you're on the very, very mild end of the spectrum, you may be wondering if someone who has an acute cough even might have pneumonia. Should you bother to do an x-ray? And this is one approach you can use to solve that dilemma. There are symptoms, signs, and absence of features that predict that someone with an acute cough will have an infiltrate on their film, suggesting that it's pneumonia. The symptoms are fever, night sweats, purulent sputum production, and myalgias. The signs are fever, tachycardia, tachypnea, and focal breath sounds, rowels and decreased breath sounds. Whereas if someone has a sore throat, rhinorrhea, or a history of asthma, that seems to weigh against the likelihood that they'll have a pneumonia when they present with an acute cough. And this has been demonstrated in a number of studies back over the years. So people with those symptoms and signs, in the absence of asthma especially, or upper respiratory symptom signs like the sore throat and rhinorrhea, those are the ones you want to think about listening carefully for focal exam findings and getting an x-ray. Biomarkers are all the rage, but they're not ready for prime time. So procalcitonin's probably been most studied, CRP less so, ANP, adrenomedulin, cortisol, D-dimer. There's hope that these will one day guide our decision making about outpatients and elderly patients with possible pneumonia, but presently they're just not adequately validated in a clinical setting. So I'm not going to talk a lot more about biomarkers, but maybe in another few years that'll be something to spend more time on. And then just always bear in mind that people can have cough and sputum production for a variety of reasons. And I've just listed some common lung conditions, and then other causes of inflammation in the lungs, pneumonitis, that are non-infectious and yet might appear to be very much like an infectious pneumonia. And I'm not going to go over those in any detail, but you have them on your slides. All right, so identifying pneumonia in summary. The clinical features of pneumonia vary tremendously with age. So in your elderly patients, watch out for people who just aren't themselves. That could be pneumonia. It could be a UTI. It could be they didn't have a good night's sleep. You got to think about all those things. There are clinical prediction rules that help to identify patients that are likely to have pneumonia. Patients with a cough who are more likely to have pneumonia than some other explanation. The biomarkers are not ready for prime time. And then just beware of the many other things. Think about the other things that might cause the appearance of pneumonia when actually there's some allergic or other inflammatory vasculitic process. Okay. So how bad is this pneumonia? Well, first of all, you might ask, why assess pneumonia severity? And what I'll try to convince you is that it's useful for prognostication. It can be a clue to the types of microbial causes that you might anticipate, and therefore a guide to appropriate antibiotic selection. And then it's important for guiding triage decisions. Does a patient need to be admitted to the hospital or not? Do they need to be admitted to an inpatient acute care unit or an intensive care unit? And these are some of the things that we can use severity assessments to guide. So this happens to be, I think, the annual profile of lower respiratory tract infections in Nottingham, England, as published by McFarlane many years ago. But I think this is what we see in every community, and it's neatly summarized. So I'm going to start at the bottom and recognize that there, in this town, 24,000 acute lower respiratory tract infections in the community. Okay, most of these are probably acute bronchitis. Most of those people do not ever seek care, but about 1 out of 3 of those people will come to the doctor's office, 8,000, and about 1 out of 4 of those 8,000, so 2,000, will actually be treated with antibiotics. Only about 1 out of 20 of those patients, 100, will be diagnosed with pneumonia. And of those, about 1 out of 5 or 20 will be admitted to the hospital. And of those, only 1 or 2 will be admitted to the ICU or will die. Okay? So you have this enormous population of people with cough and fever at the bottom, and 1 or 2 will be in the ICU or die of their pneumonia. So keep that in mind, and I'll come back to that. This is kind of a clumsy table showing all the risk factors for mortality in patients with pneumonia. And you can see right off the bat, age greater than 65 is a huge mortality risk factor. There are other patient factors. Aspiration's bad for you, apparently, if you have all these coexistent illnesses, which many elderly people do. If your physical findings are concerning because of tachypnea, fever, hypotension, extra pulmonary involvement, altered mental status, if you're on pressors, those are bad signs. And then the laboratory findings that are listed there. Later on, you may find out if someone has bacteremia, if their radiograph progresses, if it gets worse instead of better. If they do not have pleuritic chest pain, that's a risk factor for mortality, maybe implying less eager immune response. And then if you have a high-risk pathogen. Okay. So this is clumsy, but if you can remember some of these things when you're seeing a patient with a cough and pneumonia, it'll help you decide what to do with them. So really, I think if you're in the office setting or you're making house calls, which people with community-acquired pneumonia can be safely managed at home? And avoidance of hospitalization is quite appealing. If you ask patients in like a survey fashion, what would you give up in order to stay at home for your pneumonia treatment rather than being admitted to the hospital? They'll list on the order of a week to a month's worth of salary to avoid hospitalization. That's a lot of money. And plus, if you can keep someone at home and let them take pills instead of admitting them to the hospital, it's going to be markedly less expensive, and there'll be a much lower risk of complications. Okay? So, but we need to be able to identify low-risk patients. And this is how the port prediction rule, or the pneumonia severity index, came to be. It was I think it was a Medicare population, huge administrative database. And they were really looking for ways to identify people with pneumonia who had a very low risk of complications. And that's subsequently, maybe appropriately, been extrapolated to guide hospitalization decisions. Here's how it starts off. So you have a person with community-acquired pneumonia. First question, are they old or not old? And now we're using an age 50 cutoff. If they're old, then there's no hope. They're going straight to step 2, okay? If they're younger than 50, then you can consider whether they have any of these other complicating factors to get them into a low-risk group. But our patients, elderly patients, are all going to be over 50, and so they're going to go straight to step 2, which is right here. So then you need to know some things about the patient. Again, their age, all right? So they get a point for every year old they are, unless they're a woman, and then they get a point for every year old they are minus 10. If they're a nursing home resident, and this was well before the HCAP came out, they got a plus 10. If they had cancer, liver disease, heart failure, cerebrovascular disease, renal disease, extra points, altered mental status, tachypnea, hypotension, fever, high pulse, and abnormalities in laboratories, you collect points. So I'm going to show you the results from this very first paper, and then we can talk about it. The far left column shows their points, and they're grouped into risk classes. So the idea initially was that people in groups risk class 1 and 2, so less than or equal to 70 points, maybe even 3, less than or equal to 90 points, could be discharged or could be managed without admission. And then groups patients in groups 3, 4, and 5, especially 4 and 5, wouldn't need to be admitted. Okay. So that was their derivation cohort, and if they had sent all the risk group 1 and 2 patients home, they would have saved about a quarter of all hospital admissions. So that's a good thing. They also looked at a validation cohort where they applied the same rules and seemed to indicate that it would be safe to do what they had proposed to do. Now, in the validation cohort, there was only one person in class 5 who was managed as an outpatient, but he did fine. Okay, and so this is when we look carefully at this PSI score. It's highly dependent on age. So if you're 65, you're already out of group 2, just based on your age, and throw in a few of those other pesky medical problems, and it's going to put you in the hospital. it doesn't really adequately weight extreme values. So if you're young, but your PaO2 is 30, doesn't care. It'll give you 40 points. Okay? But that's not okay. That person needs to be on a ventilator in the ICU. So it's not savvy about that. And then it completely neglects non-medical indications for hospitalization, which at Harborview, I'm telling you, that's almost the most important set of factors to consider. Okay, so nevertheless, if someone scores low on the PSI, it probably warrants careful consideration for managing them as an outpatient rather than admitting them to the hospital. And it's really emphasizing the low end of the spectrum. Okay. Now on the other extreme, you're walking through the ER and after visiting someone in the hospital, and you're on your way home, and you notice one of your patients laying in a stretcher, gasping for breath. And sometimes it's obvious if someone has shock or respiratory failure, it's obvious they need to be on a ventilator in the ICU. But what we need is a way to identify people who are at high risk of subsequent physiologic deterioration, because those are the ones that really do badly. Okay, I'm going to skip over the ATS severity criteria because they're too sensitive. They identify everybody as being too sick, ICU bound. But there's a British prediction rule called the CURB 65, and it counts on confusion, uremia, high respiratory rate, and a low diastolic blood pressure in people, especially people over age 65. And if you have two or more of those factors present, then your relative risk of deterioration and critical care needs goes up by about 36-fold. So that's remained a handy rule of thumb for somebody who's not already on a ventilator, but who's old and has some IB-WEN and they're confused, and that person should go in the ICU. And this can be a way to help you make that determination. Okay, so in terms of severity, I think clinical judgment really remains critical, because you have to note worrisome features even if they are low scoring or no scoring. Okay, and you need to consider social indications for admission. We do have quantitative prediction rules, and they can help. They do help in places that offer a way to calculate them for us, identifying people who can be managed as outpatients, and identifying patients who aren't yet obviously going to the ICU, but who need to go to the ICU because of their high risk of deteriorating. Okay? All right, so what's the likely cause of pneumonia? This is kind of a fun section to burn through. For a long time, I can remember being taught that there was a typical pneumonia and an atypical pneumonia. And I've listed the criteria for each on this slide. So typical is going to be abrupt onset, a productive cough, pleuritic chest pain. Systemic symptoms are kind of mild, but for fever, white counts greater than 10. And the causes are going to be typical bacteria, whatever that means. That's pneumococcus, right? It's staph, it's a Haemophilus influenza, it's real bacteria. And the atypical pneumonia is more of an insidious onset. It's a non-productive cough, chest pain's uncommon. Aches, pains, prominent systemic symptoms are common. White count's usually normal. And this is going to be your viruses, mycoplasma, chlamydia. It turns out these, if you can really dig down and find out the specific etiologic cause, these features are pretty unreliable for predicting the actual cause. So one more reason why I think we're better off going with guideline recommended antibiotic treatment rather than trying to guess what it's going to be based on how the patient looks. Okay. These are the most common pathogens that have been identified in a couple of dozen community-acquired pneumonia etiology studies. And pneumococcus is typically the leader, but you have these other H-flu, others like Mycoplasma pneumoniae and Chlamydia pneumoniae and Legionella pneumophila are fairly common in community-acquired pneumonia, much less so in hospitalized patients. So I have an asterisk next to Legionella, and that's really just to remind me that I need to tell you that it's highly geographically variable. So we found some in our patient population at Harborview some time ago, but it's not present everywhere. If you're in Pittsburgh, you better think about it. In Seattle, it seems less of an issue. It's at the Hutch, though, and so good thing we're going to cover it. Okay. This is sort of that same data shown in graphical form and indicating data for different pathogens across the bottom and by different studies with the different symbols. And my study here is the purple and gold diamond symbol, and the gray bars are the mean of all the studies. So I want to point out these are studies done by academic centers that were highly invested in determining the cause of pneumonia in these patients. And what's the tallest bar? Unknown. Okay. So these patients had blood cultures, sputum cultures, serologies, viral cultures, etc., etc. And in this mean, it varied a lot, of course, but the mean, about 40% of the patients couldn't be identified as a cause of their pneumonia. So, but anyway, that's the data, if you must know. This is another way to look at it. So this table's a little bit malformed, but it's meant to show in all these etiology studies what the leading single cause of pneumonia was in all those studies. And every single time it was Streptococcus pneumoniae. So got to remember that. That's the number one enemy. All right. So, you know, recommendations for evaluating people with pneumonia vary. Generally, for outpatients, there isn't a mandate to do any kind of testing for etiology. But for hospitalized patients, then it is recommended that we get sputum, gram staining culture, blood culture, CBC, chemistries, some measure of oxygenation, HIV test if it's not already known, and then consider these other assays on the bottom bullet there if indicated. Okay, so pneumonia can be caused by many and varied pathogens, but hard as we try, we can only figure it out in about half of cases. And if we don't try very hard at all, we'll never figure it out. So don't rely on the atypical and typical designations because it's not helpful. And because of all the things that I just mentioned, really think about sticking to guideline-specific empiric therapy, remembering that it better cover strep pneumoniae because it's the number one cause in all these different studies. Okay, so what's the best treatment? You guys all know your guideline-based therapy for pneumonia. There's not really great guideline-based therapy for pneumonia for elderly patients, but I like this figure. Austrian and gold were some giants in the in the Boston area, following in the footsteps of Tillman in Finland before the Depression, during the Depression. So Tillman in Finland provided the untreated patient data and the serum treated patient data. And this is with bacteremic pneumococcal pneumonia. Okay. So you'd culture the blood, identify strep pneumoniae, inject it in mice, and then type the bugs to see what type their polysaccharide capsule was made of. Then you give horse serum raised against that serum, that capsule saccharide, and save lives. So the untreated people were people who had a pathogen that they didn't have serum for, and the treated ones were patients who had a pathogen that they had serum for. And so you can see just injecting horse serum in somebody was pretty effective back in the 20s and 30s before we had antibiotics like penicillin. And then when penicillin became available, then Austrian Gold showed this marked improvement in survivorship once you get past that rough first few days. Okay? So this is just to give you, you know, 2 thumbs up. We can treat this, and we can improve the outcome of people who have pneumonia. So what really influences mortality? Age, again, we're seeing comorbidities, the initial severity, as I mentioned, the microbial cause, and then none of those things are really things that we can do anything about, right? That's how someone comes to see us as a package. They've got all that. We can't change their parents. We can't change whatever bug is causing their pneumonia. We can't change their comorbidities. But we can change their site of care, their care provider, supportive care decisions, and antibiotic therapy choice and timing. Sooner the better. It better be the right one. Okay? So the management section here is what we need to focus on in terms of optimizing things. All right, so why guideline-based pneumonia management things? Really to address variability that was being seen in care decisions for pneumonia patients, standardize approaches to triage decisions and diagnostic evaluation, antibiotic selection and follow-up. Eventually to get the ATS, American Thoracic Society, the IDSA, and others to speak with one voice. And now, unfortunately, we haven't had an update on our pneumonia guidelines in about 10 or more years because all the pneumonia experts have conflicts of interest with all the antibiotic makers. They're all on the lam, getting paid to do studies by antibiotic makers. So I think they've done some good work, though, and there isn't a lot to update, really. And I'm going to walk through an example of an algorithm for how we should think about treating pneumonia patients. So first we need to identify pneumonia. Okay. We need to decide if the patient's going to be admitted or not. And then for outpatients who are not going to be admitted, we need to think about whether they have risk factors. And in this algorithm, the risk factors I'm talking about are risk factors for drug-resistant pathogens or for handling an infection poorly. Okay? So we'll talk about appropriate antibiotics for outpatients with risk factors and no risk factors. We'll talk about antibiotics for inpatients who do not require ICU care, who do or do not have risk factors, and who do require ICU care, who do and do not have risk factors. Okay? So far, I haven't told you anything, but we're going to hit each of these bottom lines here. Okay? These are the risk factors that I'm talking about for infection with specific drug-resistant pathogens, okay? So, and this is going to overlap to some extent with your healthcare-associated pneumonia risk factors. So, advanced age, recent antibiotics, alcoholism, immunosuppression, multiple comorbidities, and exposure to a daycare child. I don't hear so much about this anymore because we're talking about risk factors for penicillin-resistant strep pneumoniae. Okay, we've become less concerned about that, but those risk factors still get us thinking about resistant antibiotics, antibiotic-resistant pathogens of other types. Resistant gram-negative bacilli, nursing home residents, people with cardiopulmonary disease, other comorbidities, and recent antibiotic treatment. And then risk factors for Pseudomonas and other highly resistant gram-negatives, then bronchiectasis or structural lung disease, steroid therapy, broad-spectrum antibiotics, and malnutrition is what's panned out to be risk factors for that terrible lung pathogen. Okay, so here's our first group. This is going to be outpatients who do not have any of those cardiopulmonary disease or modifying risk factor features. Okay, we're looking for pneumococcus, mycoplasma, chlamydia, H. flu, viruses, and maybe some occasional other pathogens. And what's recommended for this group really is just an advanced generation macrolide like azithromycin or clarithromycin or doxycycline. Those were great for this spectrum of pathogens, unless it's influenza. So, and I'm going to say this right now and not again, but if it's flu season and the patient has any sort of prodrome that sounds flu-like, they should be put in isolation and given treatment for influenza while you're awaiting your specific test for influenza. Okay, that's especially true in elderly people who are nursing home residents and so on. Okay. Now here's the recommendation for outpatients. So they're not terribly sick, but with cardiopulmonary disease and or other modifying factors that increase their risk of resistant pathogens. The same sorts of drugs are present. There's a greater risk they're going to get aspiration pneumonia. And the therapy is still going to be pills, but it's going to be, sorry about the typo, a beta-lactam antibiotic. And these are, you know, second and third generation cephalosporins or amoxicillin plus macrolide or doxycycline. So that combination therapy is critical when you have risk factors for some of these other pathogens. And then an alternative to that would be just an anti-pneumococcal fluoroquinolone like moxifloxacin. Okay? The fluoroquinolone will kill the pneumococcus and the mycoplasma and the chlamydia and the legionella. And so it's actually, it's not a bad choice. All right, we're moving across from left to right on our original algorithm. Now we're talking about inpatients. So they're sick enough to be admitted to the hospital, but they don't need to go in the ICU, and they don't have risk factors. Okay. Same pathogens, for the most part, that you see in the outpatients with pneumonia. But we're going to be admitting them to the hospital, and now we're going to be giving IV antibiotics instead of oral antibiotics. You can use azithromycin or doxycycline, either with a beta-lactam antibiotic or an anti-pneumococcal fluoroquinolone again. But these are going to be given as an IV dose, not pills. So you'll assure that you have good bioavailability and so on. Okay. Now here we have our group of inpatients who are not in the ICU, but who do have cardiopulmonary disease or modifying risk factors. Okay. So here it's going to get a little more complicated. We have essentially the same list of organisms, although more risk for drug-resistant pathogens. So in this case, we're going to give an IV beta-lactam plus either macrolide or doxycycline, or an anti-pneumococcal fluoroquinolone. Starts to sound like a broken record. So I'm going to come back to these recommendations. We still have a few more groups to go through. But this is one of my favorite books of all time, Love in the Time of Cholera by Gabriel Garcia Marquez. And this is just a passage from the book that I thought was cool. Dr. Rubino arose at the crack of dawn when he began to take his secret medicines. Potassium bromide to raise his spirits, salicylates for the ache in his bones when it rained, ergosterol drops for vertigo, belladonna for sound sleep. He took something every hour. In his pocket, he always carried a little pad of camphor that he inhaled deeply when no one was watching, to calm his fear of so many medicines mixed together. All right, so I don't know if he had any medical training per se, but this is some of the data that prompted recommendations to use combination therapy in sick ICU patients especially, sick inpatients especially. And I think focusing between the dual therapy line in yellow and the single therapy line in pink or magenta, fuchsia, you can see there's a huge difference in people who got dual therapy, and this would be a beta-lactam and macrolide typically, compared with people who got only a single drug. The multiple therapy is complicated because it's all manner of junk mixed together, and it's unclear exactly what they're trying to do. So I tend to ignore that blue line. Okay? So, we had the sense that combination therapy was good for sick people. But this was just a recently published nice study comparing, boy, that's a strange title. It's meant to say beta-lactam monotherapy is non-inferior to combination therapy in less severe CAP patients. So they enrolled a bunch of people admitted to the ICU in non-ICU beds, not sick patients, but just admitted to the hospital. And they cluster randomized using a crossover design to test that hypothesis. And they found no difference in 90-day mortality in the three groups, no difference in duration of hospital stay, and no difference in the time until conversion to oral antibiotic. So it appears that in the less severely ill group, maybe the combination therapy idea isn't quite so urgent. Whereas I think the jury's still out for ICU patients. Okay. Let's skip over that, I think. All right, now let's finish off this ICU patients now who do not have risk factors for Pseudomonas. All right, so we're going to use combination therapy for the sick patients with beta-lactam plus either fluoroquinolone or macrolide. Okay. This ought to be just rote. And then if you have a patient in the ICU who does have risk factors for Pseudomonas or any of its cousins, then it's critical that you use an anti-Pseudomonal beta-lactam. There are some listed there. Plus an anti-Pseudomonal fluoroquinolone, or plus an anti-Pseudomonal aminoglycoside, and either a macrolide or a non-Pseudomonal fluoroquinolone. Now, something's become apparent to us in the time since these guidelines were published, and that is that fluoroquinolones are a good anti-tuberculous drug. So in places like Harborview, where I swear just about everyone who comes in with pneumonia gets us wondering if they might have TB, we discourage using fluoroquinolone monotherapy in pneumonia patients. So we're really encouraging beta-lactam, macrolide combinations, and less so from monotherapy with fluoroquinolones. And I think it's reasonable to use a fluoroquinolone, say, in someone who's panallergic, where you can't use a beta-lactam so easily. But we don't encourage using it routinely as an equal alternative to the beta-lactam macrolide combination. All right. So, summary: pneumonia patients should be given empiric antibiotic therapy based on the severity of their illness and their risk factors for drug-resistant pathogens. And specific therapy may be indicated if a unique pathogen is identified in your blood cultures, in your sputum, whatever. But the role of pathogen-directed therapy for routine pneumonia pathogens really is still pretty uncertain. Okay? All right, treatment failure. This is, I hope, helpful for you. What is treatment failure? The definition by the professional societies is really that represents a deterioration at any time or a lack of improvement after 3 to 7 days. Okay? So this is distinct from a non-resolving pneumonia, a delayed radiographic resolution in someone who's clinically well, a recurrent pneumonia, or a secondary nosocomial pneumonia. Okay, so this is just your original pneumonia that's not getting better or worsening on the treatment you have chosen. Okay, and I just want to buzz through some slides on how you should approach a patient like this. All right, first of all, think about getting help, and this is pretty lame, I have to admit. I like the water on the left. The haystack on the right with the needle in the haystack is, anyhow, the point is, you guys are functioning at the primary care level oftentimes, or, dealing with all manner of different things that come through the door. And the pulmonologist is sitting there kind of seeing the tip of the iceberg, the people who end up in the ICU or dead. So we have a different way of looking at pneumonia. But think about getting help. And how could we help? Well, maybe you have the wrong diagnosis. Maybe there's something about the patient that we somehow might identify. So maybe it's some kind of pulmonary complication of their rheumatoid arthritis or whatever. Or maybe it's some non-infectious pulmonary disorder that's on the pulmonary boards but not on the general medicine boards, the nursing boards, or any other kind of test. Okay. Maybe you have the correct diagnosis, but there's some kind of patient factors that are impairing their response. They're HIV infected, they're on corticosteroids that you may or may not know about. They're weak or physiologically compromised by COPD or neuromuscular weakness. Or they have some kind of a anatomic problem, a bronchial obstruction, for instance. Again, maybe it's the correct diagnosis, but it's something wrong with the bug. It's not one of those algorithm bugs. It's something very virulent like influenza, or unusual like TB or pneumocystis or some kind of fungus, or resistant. And those things we don't treat for in everybody, but sometimes we have to go back and consider. Maybe it's a different antibiotic factor like Pharmacodynamic problems. Does it cover the bug that it should? Pharmacokinetic problems. Are you giving the right dose, or is it bioavailable, particularly in oral treatment? Is the patient non-compliant or non-adherent? And is there some kind of system administration failure? You thought you ordered it, you didn't. You ordered it, it didn't get through. The patient's not getting it. Okay? And then, again, you may have the correct diagnosis, but something may have happened with the disease. So there's a complication such as empyema, or lung abscess, or sepsis. Or sometimes there's some non-infectious complications of an infectious pneumonia, like ARDS, or cryptogenic organizing pneumonia, that may underlie the reason the patient's failing their antibiotic treatment. Okay. Here's a photo of a patient with a pneumonia that's failing therapy, where on CAT scan you can see in the posterior left lower chest there's a loculated empyema with rim enhancement. And so that's typically not going to get better until it's drained. Just as one example of a complication. Here's another pneumonia. This probably should have been recognized as an aspiration pneumonia on day 1 with the upper lobe volume loss and so on, and maybe there's a little bit of air showing in the middle of it, but then by day 4, when the patient was still febrile and coughing up oodles of gook, follow-up x-ray showed that there was infiltrate with multiple cavities, necrotizing pneumonia. All right, so what do you do? Well, first of all, review the history. Make sure you understand all the contacts, exposures, drugs they've been on, travel history. Think about if they've been around anything that would be transmissible, like TB or flu especially. Repeat your physical exam. What the heck? Assess their mental status. Make sure they're controlling their secretions adequately and clearing their secretions adequately. Think about whether you're seeing evidence of a pleural collection or airflow obstruction or some metastatic site of infection. That explains why they're not getting better. All right? Confirm the right antibiotic dose and administration. Review the micro results. Are there new susceptibility results that you need to know about? And then just think about these local epidemiological trends. Who knows, maybe it's the Ebola has finally reached Seattle, Washington. And then consider getting another x-ray. You might see progression of the infiltrate, you might see cavitation, you might see adenopathy, you might see empyema. And consider repeating your micro studies and some of these other more specialty examinations. I want to warn you about repeating micro tests in people on antibiotics, though, and I'm going to show you why. This is a really old study. Back in the days when transthoracic aspirates were done. That's what TTA stands for. So this was all people who had pneumococcal pneumonia, 85 people, and they all had positive TTAs for pneumococcus when they first came in. Very few other positive TTAs, 8 H influenza and 0 staph, enteric gram-negatives, or Pseudomonas. They got antibiotic treatment, and then they repeated the sputum and repeated the TTA. Okay, and look at all the stuff in the third column over sputum after. Look at all the stuff that grew out of the sputum. Staph, enterics, Pseudomonas, a ton of trouble. But in those same patients, the TTA, which is sampling the airway itself, very few positive cultures. So beware. If you give someone antibiotics in the hospital, especially, their flora will change. Okay. The other things we're seeing a lot of now in the hospital are C. diff colitis, nightmare, and fungal sepsis in people who've been on broad-spectrum antibiotics for a long time. All right, so don't bet if you grow E. coli or Serratia out of someone's sputum that that's their new cause of pneumonia. Okay. This must have been studied, right? Actually not really. But hospitalists, as opposed to generalists, usually accomplish shorter lengths of stay, but discharge more patients with unstable clinical parameters. This is the kind of thing you can identify in an administrative database. And consultation of specialists is pretty rare overall, even among people who are hospitalized and dying. So we're available. This is a little bit better done prospective observational study of CAP management by primary care docs compared with the ERS guidelines. So what they found was many low-risk patients were being admitted. There was no association of diagnostic use and severity, and a lot of over-treatment in low-risk groups. So treating everyone as though they needed 3 different antibiotics, maybe. And then the severe group, where you would want to see that kind of therapy given, those people were undertreated, leading to increased failures and increased length of stay. So I'd say, in summary, if you're not a specialist, don't be bashful about consulting a specialist when someone has a problem like pneumonia that requires hospitalization. Okay, so 2 heads are better than 1. Pulmonary and ID consultants have more experience with infectious and non-infectious pulmonary diseases. We have specialized procedures that we have available to us, and we can proceed to more intensive supportive care pretty effortlessly. Okay. On the other hand, 2 heads cost more than 1, way more. And there's a lot of managed care pressures on all of us to lessen consultation and lessen expenditures. There may be some kind of diminished stature or role for PCPs and other physician extenders. And the specialists are going to do more costly and morbid procedures for sure. And there's really not a definite link to better outcomes. So, all right, so pneumonia is common and it's potentially very serious. It can fail to respond to antibiotic therapy. Treatment failure should prompt review of the situation, and consultation is recommended for severe CAP and for treatment failures, especially if there may be a need for specialty intervention. Okay. How do we prevent pneumonia? This is my short list, and I spend most of my time in my clinic getting people to quit smoking. Everyone now with COPD gets their flu shot at the Bartell drug, and most of them have had 6 or 8 pneumococcal vaccinations, but getting them to quit smoking is tough. And this is my final summary for this didactic part of the presentation. It's a big health problem with known risk factors and pathogenesis. There are clinical prediction rules and biomarkers that we can use to identify pneumonia and triage CAP patients. And the causes can be predicted.
Questions?
Empiric therapy is what we should use based on guideline recommendations. Okay? Now, it is 5:09, and we have until 5:30. Should we answer some questions now? And then I have some cases if we have time. Okay? Are you going to read the questions?
I'll read the questions, and I'll ask right now if there's any questions here in the room while people out there are formulating their questions.
Clear as a bell.
It actually was very clear.
The atypical pneumonia, would that be what the technical term walking pneumonia?
And I'll need you to repeat the questions that come in
yeah.
here.
The question was, when I say atypical pneumonia, does that mean walking pneumonia? No, not really. I would encourage you to avoid those terms. I think walking pneumonia is a great term. Another one I love, but I don't know what it means, is double pneumonia. I had double pneumonia. I don't know what that is, but it sounds bad. We have something at Harborview too called walking ARDS. So I don't think that's really a useful term, other than it implies a lower degree of severity in a patient that's not bedbound but can get up and around, and that's how we like to manage people, even with ARDS now. Get up and move.
Other questions here?
Is delirium common then, and that's the recommendation, to do a mini mental or check?
Is delirium common in people with pneumonia? Well, in elderly people who are hospitalized, delirium's common, and especially if they're sick, if they have pneumonia or some other illness. Yes. So it's in the prediction rules because it's evident at the time of admission. It's great to see an older person who can be hospitalized, treated for pneumonia, and recover without ever becoming delirious. But it's very, very common to see that, and we try to minimize the impact of that on their well-being.
So someone is wondering, would you use amoxicillin if you were concerned about DRSP?
So another factor that, do I need to repeat your question? No. Another factor related to these out-of-date guidelines is that we don't care so much about DRSP anymore. And the reason is that it's been recognized that we give amoxicillin and cephalosporins and other drugs in fairly good concentrations, so that even drug-resistant strep pneumoniae is susceptible to killing by those levels that are achieved. So yeah, I would use amoxicillin, or I think our online ordering system at Harborview calls for ceftriaxone and azithromycin for in patients who are sick or have risk factors.
Wyoming is wondering, why is hantavirus so deadly?
Super, super virulent, right? Just like flu. Influenza killed, does anyone remember 1918? Anybody around? No. Influenza killed, I want to say 18 million people, maybe it was 22 million people in 1918 and 19, because it's so virulent, and there was no immunity to it. Hantavirus, same deal. We've never seen it before. We get exposed to it, and it rages through our body, our lungs, our kidneys. All the septic mediators are turned on. So, yeah. Fortunately, now maybe in Wyoming you're seeing more hantavirus, but we're not seeing so much of it around here anymore.
So Anchorage is asking, does the vaccine cover all forms of pneumonia?
Well, there are two vaccines that are typically used to prevent pneumonia. One is the flu shot, and that has to be received every year. And what they try to do is, by studying what's going on halfway around the world earlier in the season, they try to get a sense of what strains to cover. And so then they craft billions of doses of the strains that they predicted were going to be our worrisome clinical strains, and everyone gets the vaccine. This year, some of you may have heard that the vaccine strains didn't work so well. So people who got vaccinated still got the flu. But all I can say to that is that, well, we're doing the best we can. It's difficult to predict. You can't vaccinate someone against every known influenza strain, so we try to pick the ones that are most likely to be common and virulent. The other vaccine that's used to prevent pneumonia is the pneumococcal vaccine. And the antigen on pneumococcus that we vaccinate against is a polysaccharide as opposed to a peptide or protein antigen. So the pneumococcal vaccine's never been very good at stimulating an immune response. And now there's a new conjugate polysaccharide protein vaccination that seems to be a lot more effective. So that's being recommended every 5 to 10 years for people at risk for pneumonia. I'm not aware of any others. If anyone is, please shout out.
What is the evidence-based data for antibiotic duration and number of days IV before changing to PO?
There's pretty good evidence that you can switch from IV to PO antibiotics as soon as the patient's stabilized. So if they're eating, drinking, taking oral, not vomiting, switch to PO. As far as how long to continue the antibiotics, we have no idea. Probably a week or 10 days is sufficient for most pathogens. It's possible that some people would be cured with far shorter duration of therapy. Some people appear to need a lot longer therapy, and those include people with abscesses or necrotizing pneumonia. And then if you have a pleural collection, that if it's infected, it needs to be drained in order to resolve.
Why did you have a question mark next to bronchoscopy? Was it with regards to various settings and the clinical utility of BAL?
I think it'd be unfortunate if we bronched everyone with pneumonia. And so I want you to be aware of that as an option, but it wouldn't be the first thing we would jump to in most people who are failing your empiric treatment for pneumonia.
I don't see other questions coming up yet. Any others here in the room?
Thank you. Another regional one. Pneumonic plague seems to be bad again this year. And is that in the pneumonia spectrum?
The question was, is pneumonic plague in the pneumonia spectrum? So there are some strange infections, and pneumonic plague is one of them. Anthrax, inhalation anthrax. Ooh, spooky. So really to identify people that are at risk for those kinds of infections, it's really critical to identify their risk through your history taking. And nobody is going to be treated empirically for hantavirus. There's no treatment for plague or for anthrax. But if you know they were exposed, then that's critical information. So, now what are the risk factors for, say, anthrax? Lately, it's like getting stuff in the mail, right? Getting white dust in the mail. But traditionally, it's been, handling wild animals, right? And what about plague? How do you get plague? There's bubonic and pneumonic. We're talking about pneumonic plague. How do you get that? Same, right? So you have to be exposed to the organism, and it's usually causing wild animal infections. And so it's the people who are at risk are hunters, gatherers, butchers, people like with that kinds of exposure. I don't know if I answered your question. We see an occasional case, usually from eastern Washington, that's usually already been identified by the time it gets to us.
So I don't see other questions coming up. If you wanted to go through a case.
Sure. Yeah. All set here. Okay, let's go ahead. These are just some cases I collected over the years. I don't know if they're really terribly relevant, but let's go through some. So 64-year-old woman, she old, I'd say, confused, unwell for several days. So that's your pneumonia. She has a non-productive cough, dyspnea, and came to the ER. Oh, she's got chronic alcoholism. Her white blood count's 18,000. Creatinine's elevated, BUN's, bilirubin is elevated, and her blood gas is concerning. Metabolic acidosis and hypoxemia. All right. Here's her film. This is a really sick lady. She's intubated. She has a PA catheter. And how would you describe her x-ray? Little touch of something. It's almost white out. There's a little sparing in her right upper lung. And that green arrow is, how did that get there?
Left click.
Is that you back there?
Yes.
Okay. So what do you think's going on? You guys aren't ICU doctors. But she has a very severe illness, probably due to pneumonia, and it's causing septic shock and ARDS. And here's her sputum gram stain. I didn't talk a lot about gram stains, but they're sprinkled through these cases. These are lancet-shaped gram-positive diplococci, and you can see some of them have a nice capsule around them. So this is Streptococcus pneumoniae. Over the course of 2 or 3 days, she went from pretty healthy elderly woman to, well, not even slightly old woman, to nearly dead. Okay. This is what we decided to call her within a day or two. And she recovered, but it was a long, hard slog. All right. This one's a little better. Also odd. 74-year-old man. He's been coughing for 3 months. Scant sputum, low-grade fever, and weight loss. He's been treated with 3 different courses of antibiotics. Not sure what. And he gets a little better each time, and then his illness returns quickly after he stops. And the interesting thing about him is that he'd had a thoracoplasty when he was a young man for treatment of TB. He's nearly febrile, not quite. Normal pulse, respirations, blood pressure a little high. He's kind of gaunt, but neatly attired man, accompanied by his wife, who's very concerned. And he has this obvious chest wall deformity and decreased breath sounds on his right side. So here's his PA and lateral film. And man, this is a very abnormal X-ray. And what I couldn't figure out is how much of this could be scarring from the TB and the thoracoplasty versus something new related to his present illness. But we found an old X-ray. Let's see if I can bring it up. There it is. So this was his long-term stable appearance after his thoracoplasty. And so this is an unusual case, but I was concerned that he had recurrent tuberculosis. He'd never really been treated other than by collapsing his lung. And his illness seemed more like a chronic indolent thing than an acute pneumonia. All right. We got some sputum. They were all AFB smear negative, and we finally ended up doing a bronchoscopy to see if he had an airway lesion or something. We lavaged the area that was involved, and I don't know if you can see this, but these are leukocytes, the big things, strands of mucus, and within the strands of mucus, hundreds of little teeny tiny gram-negative coccobacilli. So that we recognize as H. flu. And what he had was something that's been reported that's called chronic pneumonia syndrome. So it's been H. flu all along, probably. And he got treated, did a little better for a while, then it came back. So we gave him 6 or 8 weeks of antibiotic, and he did fine subsequently. I got another X-ray. Yeah, here's the lowdown. And then his post-treatment film, now a couple months later, is nearly back to the way it was forever. Okay, 57-year-old woman with 3 weeks of fever, cough, and chest pain that did not respond to antibiotic treatment. She has Takayasu's arteritis, and that requires that she takes prednisone. She has low-grade fever, tachycardia, tachypnea, normal blood pressure. And her chest actually sounds clear, but when you examine her chest wall is really tender. Normal white count, but her glucose is elevated at 240. Let's see what she looks like. What do you think? I didn't do a very good job choosing cases that you'd be likely to see in the outpatient clinic. But
It's interesting.
yeah, these are interesting cases. She has multiple nodular opacities, many of which appear to be cavitating. That's what this appearance looks like to the experienced eye. Okay, so we ended up aspirating one of those, and this is what we found on the gram stain. Again, neutrophils, mucus, and these fine branching beaded gram-positive rods. And I think we got another stain of it. This is a Kinyan stain, a modified acid-fast stain. So when you see this gram-positive rod thing that's AFB smear positive, that's nocardia. So this was pulmonary nocardiosis.
Interesting.
Okay, I'm doing a terrible job of plain ordinary pneumonia. This one might be the closest. 63-year-old, 2 days fever, chills, cough, chest pain. On hemodialysis after failed cadaveric renal transplant, and has prednisone and Imuran therapy for bullous pemphigoid skin disease. High fever, tachycardic, tachypnic, hypertensive, but not as high as usual. And he's dyspneic and confused, has consolidation of his right chest, high white count, U1 creatinine, lowish glucose, and a CPK of 541, which is a little unusual for your typical pneumonia patient. Sorry for saying typical. Okay, and this is why I think it's important to treat people like this who are acutely ill and requiring ICU care. It's important to treat them with combination therapy. So what do we see here? The PA view shows a lot of disease in the right upper and middle lobe. And I'm going to tell you that the appearance of infiltrate in the left lung is just this pectoral muscle shadow. Okay, and then on the lateral view, you can see that it's in the upper lobe in front of the major fissure and down next to the heart in the middle lobe. Okay, so it's at least bilobar pneumonia, and it's made him very sick. So any ideas? Any thoughts pop into your head?
Somebody's saying PJP.
Yeah, it's a little odd to see such focal, dense consolidation from pneumocystis. So I don't think that's so likely. Oh, Legionella antigen. Who is that? CAICHC. Good idea. That was your third guess, fourth guess. So, yeah, so here's the gram stain from sputum. We didn't ever bronch him. But notice all the neutrophils and no organisms in sight. So we're thinking already this is some, now we can start saying this must be some odd virus or bacteria that doesn't show up on gram stain. Okay, and the one that's likely to cause septic shock and focal pneumonia is Legionella. So, good guess. Now, you can culture Legionella. It takes about 5 days to grow. So if you wait until the culture comes back before you treat it, they're toast. Okay? The Legionella antigen you can send on the urine, and it'll come back within hours, hopefully, if you're in a somewhere close to civilization. And then you'll know right away that you're on the right path. But hopefully you're going to be covering that with your macrolide therapy, along with whatever else you give them. Parenthetically, you can send urine for pneumococcal antigen too, and it has the same relevance. It's highly specific, even in people who've been treated with antibiotics already. Or pneumococcus kind of goes away immediately, but not before it stirs up your host response that causes your sepsis and your ARDS and so on. But the antigens will be released and appear in your urine for several days thereafter. Okay. Let's do one more here and then we'll call it quits. 68-year-old homeless alcoholic man, 10 days mild, just dry cough, sore throat. What does that sound like? Achy. Yeah, doesn't it? Sounds like flu. But now he has 2 days of high fevers, chills, cough, and chest pain. This is kind of a classic biphasic illness with a flu-like prodrome and then a bad pneumonia that follows. So you'll see this. And he's febrile and tachycardic, tachypnic, and a little hypotensive, and tremulous, and confused, rattling cough, high white count Billy, alcohol 55, right on. Here's his x-ray. So this is really more of a right upper lobe consolidation. No middle lobe or lower lobe involvement that we can see. And here's his gram stain. See anything? white blood cells, mucus. I guess I'll use this pointer. Where to go? There we are. What is that thing? Or that thing? Or that thing? What are those? Those are bacteria, gram-negative rods. Okay. So probably he had influenza. It wiped out his mucociliary escalator. And then